Oh, sorry, Alicia, how do I advance the slide?
Just, there you go.
Beauty.
Yes, and then back.
Perfect. Okay.
All good?
Yeah.
Okay, cool. Hello, everybody. Thanks so much for coming. Today we're really lucky to have Professor Marty Ewer, who's a prominent psychiatrist here in South Australia, talking to us. So it's part of the Open Door Seminar series. Just for the room, Marty, got Andrew Previtt down here. He's our PhD student. He's a veteran and ex-SAPOL. I mentioned that, sorry, mate. And he's doing his research on the reformation of the veteran sector. He is. So we've got Pete Newman here, Colonel, I think. Yep, Lieutenant Colonel, sorry. And Pete's just sort of on his transition journey. Yeah, and you know this character, David Everett.
David, yeah.
And this is Professor Amy Hamilton. She's the artist in residence for the Open Door project, so she does a lot of artwork. And Professor Justin Mills, Deputy Director of Open Door, and Professor Tim Windsor, who's sort of a leading expert in generational and aging and those sorts of things as well. So thank you all for coming. Appreciate it. Come on, phone, do what you're meant to do. So, Marty's a psychiatrist in private practice with expertise in PTSD, depression, and anxiety. He's been trained to run trauma-sensitive mindfulness-based stress reduction groups and developed a PTSD treatment program called Mindfulness and Somatic Trauma Processing, Reprocessing, MASTr in capital. Using trauma-sensitive mindfulness, mindful self-compassion, trauma-sensitive yoga, somatic experiencing, and EMDR. Marty is an experienced medico consultant. Thanks, Marty.
And you've covered it all. I don't need that. Well done. I know you're competent, but yeah, well done. Oh, thank you for that kind introduction. And when I was preparing this talk, I was advised to consider leaving out the neuroscience. And I gave this thought. And I thought it was a bit like leaving out Eric Clapton's guitar work from the Beatles, While My Guitar Gently Weeps. It's true that without Clapton, you've still got the four Beatles, and most of the other songs feature the four Beatles. But leaving out Clapton playing that red Les Paul guitar that was known as Lucy would so change the song, it would remove its heart and soul. And I thought leaving out the neuroscience of this talk, which really has guided me, would do the same to the talk. I still feel excited every time I hear Clapton play that guitar. And I feel a sense of excitement and awe each time I read about the neuroscience of trauma and the advancements and how it guides our treatment. So I hope perhaps that you may listen to that song again, and that perhaps you may approach trauma with an excitement and curiosity that will enable you to change people's lives for the better. 60 to 75% of people in the Western world experience a traumatic event. PTSD prevalence in the general population is 5 to 10%, and 11% of Australians experience PTSD at some time during their lives. 17.7% of Australian veterans experience PTSD within the first 4 years following discharge. And the nervous system is profoundly different after trauma. I told you it wouldn't take long for me to mention neuroscience, but it's true. PTSD causes significant changes to the brain's capacity to regulate threat responses, attention, mood, relationships, and it leads to very significant emotional, social, and occupational impairment that can persist long after the trauma has passed. In terms of treatment, if we look at prolonged exposure and cognitive processing therapy, they do result in symptom reduction, but 60 to 72% retain the PTSD diagnosis following those evidence-based treatments. Moreover, dropout rates from PE therapy can be as high as 36%. And I felt that whilst trauma does lead to some cognitive thinking changes, it's fundamentally experienced at a much deeper level that involves the body and the nervous system. And therefore I thought that trauma-sensitive mindfulness would help people recover from trauma symptoms, including PTSD. And therefore I commenced a training journey that has continued for many, many years. John Kabat-Zinn has described mindfulness in a way that has stood the test of time, paying attention on purpose to the present moment in a non-judgmental way with curiosity and compassion. And he developed the mindfulness-based stress reduction program to help people with a range of physical and psychological problems. In the years since he developed that program, we've understood that three networks in particular are affected by trauma. And it is really helpful to understand these. And if you've ever read any of the work of Professor Ruth Lanius, she is a wonderful expert and has done some really innovative work in helping us understand each of these networks. So the default mode network is to do with our sense of self, and it contains our autobiographical memory, our capacity to think about the future, our social cognition, ability to understand what others are thinking and feeling, and which helps with empathy. So Ruth Lanius has shown that with trauma, the default mode network often goes offline. Therefore, people often don't have a sense of self. They can feel bored or empty. And the only time they feel a sense of self when it comes online is when they're taking risks or reliving the trauma. So you probably now know that risk-taking is one of the diagnostic criteria of PTSD, and we think this is why it's the case. And she's done some beautiful research on this. The core functions of the salience network, which the PTSD also affects, is the ability to detect internal and external stimuli, to switch between important networks, to integrate emotion, cognition, and body awareness. And these things all are affected by PTSD. And then we get to the central executive network, the thinking cortical part of the brain. It contains working memory, attention, focus, control, and that's really important with PTSD because it often goes to things that are perceived to be threatening. It helps with problem solving, reasoning, cognitive flexibility. And there's a theory that has influenced myself and many other people in this field called the triple network model. And it illustrates that the interplay of these three networks is affected by PTSD. I won't go into the exact detail, but I'll mention a few examples. And I was really excited many years ago when I saw that mindfulness can improve both connection within a network and between other networks. So as I mentioned a moment ago, people with PTSD show reduced default mode network activity, so they often don't have a sense of self except when they're risk-taking, and there can be an increased connectivity with the salience network, that they're picking up things that maybe aren't that relevant or salient, and this can lead to hyperarousal. And an interesting thing, Professor Bessel van der Kolk showed that the central executive network often goes offline when trauma material is presented and when it's recalled. Not only does it, so that means the thinking part of the brain is often not accessible to us in trauma. In particular, the Broca's area to do with speech goes offline when trauma is recalled. And hence, I think the term unspeakable trauma, it's partly because people lose access to Broca's area and can't actually describe what's happened to them. And Shakespeare wrote about this in Macbeth after the murdered king's body was discovered. He refers to this, all that time ago. So mindfulness targets a number of core PTSD symptoms, and the main ones are avoidance, hyperarousal, emotional numbing, dissociation, negative emotions such as shame and guilt. And the three components of mindfulness which are thought to promote recovery from PTSD include having some attentional control, a mindful cognitive style, which means being able to observe phenomena, including thoughts and emotions and trauma material, rather than being drawn into it. And non-judgment promotes a willingness to be with troubling and traumatic material, and it reduces avoidance. So, as I say, mindfulness helps with many of the PTSD symptoms, and an important part of mindfulness is developing kindness and compassion. I went to a talk by John Kabat-Zinn, and he said, look, if he had his time again, he may not have called it mindfulness. He probably would have called it heartfulness, because the compassion component is so important. And in my experience with veterans, often through the ADF training and then through the trauma and the PTSD, they are so hard on themselves. And just starting to recognise suffering and to be kind to themselves can be profoundly helpful. Paul Fruin and Ruth Lanius have done some work showing that mindfulness helps with reintegrating the sense of self, which is that sense of self, given the problems with the default mode network, is often adversely affected by trauma. So that's really interesting work. Now, mindfulness-based approaches, it all sounds good so far, but it can actually increase distress. So I needed to turn my attention to this, and it's really well covered by David Treleaven, and he's written about a book on it in 2018, Trauma Sensitive Mindfulness. And he noted that yes, in many people, mindfulness could help people recover from PTSD, but he also noted the work of Willoughby Britton, who is Associate Professor at Brown University Medical School. And she wrote about the possibility of mindfulness unintentionally re-traumatizing people. So David then introduced us to trauma-sensitive mindfulness, and this just made so much sense for people with PTSD. And some of the key principles that he identified were understanding the trauma physiology, hyperarousal, hypoarousal, and how to respond to those, prioritizing safety and choice. I don't know if any of you have been on a 10-day silent retreat, but it doesn't feel very safe, or there's not much choice. You are not allowed to speak to anyone for 10 days, and it doesn't feel there's much choice. So introducing choice and safety is, he thinks, is really important, and so do I. A balanced attention. So with traditional mindfulness, it might be primarily inward, but sometimes to do something that might be regulating, it might be having the person be mindful of something around them. Modifying the anchor, it's traditionally breathing, but that can lead to problems if there's hyperventilation and anxiety. So using different anchors. Working within the window of tolerance, and providing integration and support, and having a flat hierarchy In traditional mindfulness, it really is, there's the teacher and there's the students. With the MASTr program, there is this flat hierarchy, and I'm there as a fellow traveller, being curious and exploring with mindfulness. So what does this look like in a bit more detail with the MASTr program? I offer options instead of directives, and that really is very different to, if you've done any yoga, that's quite different to how mindfulness and mindful movement has been done traditionally. Normalizing shifting attention when people feel overwhelmed. That traditionally has not been an option with mindfulness, but it is with trauma-sensitive mindfulness. Using shorter practices, giving a relational container, so that connection between myself and people, and we do it as a group, so there is that connection with other veterans. The language is different. With traditional mindfulness, it's bring your attention to the leg, which if you're prone to dissociation and with a lack of interoception, if you can't feel your leg, that can be almost a bit dissociating. So I do refer to your leg or your arm. And the goals of the trauma-sensitive mindfulness is to help people benefit without being re-traumatized, and to build self-regulation, resilience, empowerment, and to make mindfulness a vital resource. And I underline that because I use it as a resource with the EMDR, the eye movement desensitization and reprocessing. And it also allows for reprocessing and integration of trauma in its own right. There's some really interesting work showing that mindfulness alone, without other things like EMDR, can lead to processing of trauma. And I saw that because for the first few years, I didn't have EMDR in the program, and some people just did really well and they got the benefits that you would normally expect with EMDR. So if we just look at some of the things that mindfulness helps, if I just go into a little bit more detail with that, it does help with top-down modulation of the emotional areas, the limbic regions, by increasing prefrontal activity. The amygdala, the fight or flight center in the brain, is enlarged after trauma. Mindfulness, 8 weeks of mindfulness has shown to reduce the size of the amygdala. Mindfulness is associated with an ability to bring on the default mode network when it's required, but also to put it in the background when it's not required. Mindfulness is associated, as I've already mentioned, with increased connection within networks and between networks. And it has been shown, another part of the brain, the thalamus, which is sort of the pot that in which the soup of incoming sensory material is mixed and then divided up. The thalamus doesn't work so well after trauma, and mindfulness helps with that. Now, one of the key problems that many people have after PTSD is that lack of interoception, the inability to feel things within their body. So mindfulness has always had it's a body-based practice. So bringing attention to parts of the body in a very measured way is helpful with trauma. So the sort of things might be just a sense of grounding. So with PTSD, people may be stuck in the past due to flashbacks, and focusing on feet touching the ground may help people distinguish from past trauma then to now safety. Bringing attention to what you feel in your body has been shown to be helpful in regulating the nervous system. It restores that ability to feel physical sensations, and it helps reconnect people with their body. Often people say after PTSD, I feel disconnected from myself, and this is helpful in overcoming that, and it does support emotional regulation. Now, I started with mindfulness, and then I looked at methods used to treat trauma that are thought to be helpful, and I saw a very strong link with mindfulness. So obviously trauma-sensitive mindfulness is one of them. Trauma-sensitive yoga, Bessel van der Kolk has done some really good work on this and written a very interesting paper on how useful that is after PTSD. EMDR, eye movement desensitization and reprocessing, the more recent modification of that, EMDR 2.0, uses a different mechanism of action, so they're often used together. Phil Manfield's flash technique. And just in the last year or two, I've done some training in deep brain reprocessing and reorienting. And I think that also is very much based on mindfulness. So EMDR is recommended by the organisations that you can see on the board. So it's accepted across the world for treating PTSD. And I had the very good fortune to meet someone who trained with Francine Shapiro before she developed EMDR, and she had been trained in mindfulness. And when you look at EMDR, it's got really important, I think, it's very much based on mindfulness. So mindfulness and EMDR both focus on present moment awareness. They both encourage a dual awareness of present moment and past. They both focus on emotional regulation and distress tolerance. They both emphasize a somatic awareness of the body, and they both seem to have similar mechanisms of action on the brain networks that I mentioned earlier. And I was really impressed by some studies showing that EMDR restores the balance to those networks that I mentioned earlier. So it was really with this background, seeing these things, and I was very excited about these things. I spoke to my good friend Sandy McFarlane. I said, is anyone else doing this in the world? Because he travels and he knows the world of PTSD. And he said, Marty, there's no one else doing this. This seems to be something different and new. So with his guidance and encouragement, I developed the 8-week mindfulness and somatic trauma reprocessing program. And very fortunately for me, the letters of each of those words spelled out the word MASTr trauma. So I thought, oh, well, I'm off to a flying start here. And the MASTr program offers a comprehensive online trauma-sensitive, group-centered approach to trauma therapy with a strong emphasis on the methods that I mentioned in the previous slide. It didn't initially have the deep brain reorienting, but it does now. And we conducted some research on the program, and we did a 12-month pre-post study comparing the MASTr program with people on the waiting list. And the PTSD was diagnosed by a psychiatrist using DSM-5. Participants were also assessed using the PCL-5. So if they didn't get that's the PTSD checklist, if you're not familiar with it. If they didn't score 33 on that, they didn't qualify for the study. And we used the PCL to monitor people's progress. Secondary outcomes that we looked at were depression and anxiety with the K10 and alcohol consumption using the Audit C. And we collected data from 88 participants at intake, start and treatment completion, and then from a smaller number at 3-month follow-up. And participants' symptoms did not change when they were on the wait list. So when people went on the wait list for this study, no other treatment was engaged in, and they were essentially waiting to begin the program. Completing the program resulted in a statistically significant improved PCL5 score. So that's on the board going from 53.4 to I think it's 30.6. So that's below the cutoff of 33 significantly. So that indicates a very significant improvement in PTSD. And so not only was there an improvement, but Jane Fisher, who did the statistics, said that was a large effect size. And then at 3-month follow-up, the improvement was not only maintained, but showed further improvement. Turning to the K10, whoops, sorry. Sorry, for some reason the K10 isn't there, but essentially the K10 results were also quite similar. No minimal change during the being on the wait list, which was often 2 to 3 months, significant reduction, and then a slight further reduction at 3-month follow-up. And looking at the K10, 83% saw positive improvements on the K10. So when I reviewed these findings, these results show that participation in the MASTr program is associated with clinically significant reductions in PTSD symptoms, psychological distress in the form of anxiety and depression. I didn't mention this, but also there was a significant reduction in alcohol consumption. And with effect sizes comparable to other recommended forms of therapy. And at 3-month follow-up, participants' clinically significant reductions in PTSD symptoms, anxiety and depression were not only maintained, but there was further improvement. This strongly suggests the effectiveness of the MASTr program may be comparable to other recommended treatments for PTSD. So the program resulted in overall improvement with PTSD, but we noticed a specific effect on certain PTSD clusters. So for example, cluster B, the intrusion symptoms improved the most, so flashbacks, intrusive recollections, and cluster E, the alterations in arousal and reactivity, was the next one that improved the most. And I thought that made sense from the model I was working from, that the processing reduced the intrusion symptoms, and a combination of the processing and the trauma-sensitive mindfulness reduced the arousal and reactivity. The MASTr program was well tolerated. There were no significant safety concerns identified. We found the program to be safe, even in participants who experienced significant developmental trauma. And 33% of our participants experienced their first trauma before the age of 11 years. And that's really very important, because developmental trauma often has a different effect than trauma at a later stage, and probably familiar with the work on veterans that show that, sadly there is an increased risk of developmental trauma, and one of the theories is that maybe they're looking for another family to replace the family they didn't have, so that they're overrepresented in the military. But the fact that we still got these good results with a population where 33% had experienced trauma, the first trauma before the age of 11, was really significant. And it suggested that the MASTr program is effective in reducing PTSD, regardless of the timing of the first trauma. And also, as it probably comes as no surprise to you, most of the people in the study with the military backgrounds had multiple traumatic events. So given that they began early in childhood, multiple trauma involving people, and the problems with identity, you know, if we used ICD-11, a number of the people probably had complex PTSD. Because, and another conclusion I made was that given a third of the population had trauma that was not military-related trauma and was developmental trauma, I concluded that the MASTr program is likely to help people who who haven't experienced their trauma in the sense of the military. Another important finding is that the study supports the safety and effectiveness of group therapy. There are some other models for group EMDR, the work of Ilan Shapiro and Lucy Artigas. They've done a lot of work in that area. But I looked at their models and thought, well, should I use them because they're well researched? But I felt a more robust form of trauma processing was required, and that's why I modified the standard EMDR. But it does show, I think the largest number in a group when I ran it was 22. So I think it does support the safety and efficacy of group therapy, which is consistent with other work in the field. And this really has important benefits for efficiently using resources. Part of the reason this came about also in the first place was because I just didn't have people I could refer to. There weren't people trained in EMDR, EMDR 2.0, trauma-sensitive mindfulness, mindful self-compassion, DBR. I just couldn't find, and if I did find them, they had waiting lists of a year or more. So I think it's really helpful to use these limited specialised resources. The fact that it's done in a group setting reduces the effective cost of this very highly specialised therapy. Participants said that different parts of the program helped them. Some people found the EMDR really helpful, others it was the 2.0. And I think offering an eclectic combination of therapies in the same program offers people the opportunity to find a therapy that is likely to help them. Participants commented that they felt able to approach their trauma material because of their regular trauma-sensitive mindfulness practice that encouraged curiosity, non-judgment, and the ability to observe what was happening in their body rather than going into their thoughts and past. Several said they felt able to approach trauma material because others were doing so at the same time. They looked around the Zoom room and saw that other people were doing this, and they felt emboldened by that. And they also said, a number of people said, look, don't think I could have done it if I was in a group of people or I wasn't in my own environment. And Ruth Lanius has commented on this. I did a training session with her, and she said many of the people she helps feel they do seem to do much better with telemedicine than they do in person because of the safety of their environment. Only one person dropped out during the whole year, compared to, say, the 36% that I mentioned earlier with prolonged exposure. And that's a real strength of this program. It suggests that the program is well accepted and well tolerated. In finishing, I'd like to perhaps, I think the people I work with probably are much more articulate about trauma and the effects than I am. And so I'd like to finish with the words of Rob, not his real name, but I'll read it out. I completed the MASTr program in 2023 and was quite sceptical about it. I'm hesitant to use the term life-changing, but the MASTr program was as close to life-changing as it can get for me. Prior to the MASTr program, I was lucky to be sleeping 3 to 4 hours a night due to nightmares, and I was so tormented by debilitating flashbacks that I could barely function in my normal life. Post-MASTr program, my sleep improved and I averaged 6 hours of sleep per night, and the frequency of my nightmares has reduced considerably. In addition, my debilitating flashbacks and other associated issues no longer paralyze or have a grip over me. I attribute these improvements to the MASTr program, particularly the EMDR. The EMDR was like magic because it improved my sleep, reduced my nightmares, and made my flashbacks appear as if they were in the distant past. I can confirm the MASTr program was successful in treating my PTSD. Thank you. That's the end, and got time for questions if you wish.
Thank you, Marty. Yeah, we'll open to the floor, Andrew.
Thanks, Marty. Appreciate the talk. Just a quick question. What are your thoughts about the association between PTSD and moral injury? Do you have any thoughts on that?
Yeah, I went to a very interesting presentation on that. I think it was at the Boston International Trauma Conference a few years ago. I can't remember the name of the speaker. At face value, Andrew, I think there's a lot of overlap. They seem very similar, but the person whose life work was moral injury argued very persuasively that they are very different things, and that PTSD has its own set of symptoms and changes in the nervous system, and moral injury can be very well understood from the perspective of people being asked to do things that really go against their family training and morals and ethics, and that many of the things people present with are very understandable. And she likened it more to grief. We would see grief, we wouldn't pathologize grief, we would see it as a normal psychological process that almost everyone goes through. And she made the point that almost all of us, if we were being asked to do things that went against our own moral and ethical background and upbringing, we probably would experience psychological distress. So she felt very strongly. Not everyone agreed with that, but I think she probably didn't say it explicitly, but I think it's a bit like grief. It may well then go over the line and lead to a pathological state, which is PTSD, but it sort of made sense to not treat it as an illness initially. But having said that, she was treating, I use the word treat, it can't get away from that language, but she was using EMDR to help people very effectively. So, she was using a trauma therapy, but she didn't, I guess it might be semantics or language, but yeah, that's my understanding, how I see it.
Excellent, thank you.
I was also going to thank the person who turned the air conditioner on. That was it was real. I don't know if it was just me, but thank you.
Yes, we have a question from Reg. He wanted to know the percentage of the group who fell below the PCL5 cutoff.
PCL5 at the end. Let me see. Yeah, I just can't think of that figure just off my top of my head, but I think it might have been, I think it was like 60%. It was a high percentage. Could be 70%, but a lot got below the 33 cutoff.
G'day, Cam here.
Yes.
I was wondering, as you were speaking about, there's so many different modalities in the treatment, and first off, the thing that you mentioned is it's hard to get people that are specialised in some of these things, let alone kind of all of them. Do you see that as a barrier to this being implemented, like more broadly?
Yes, that is a problem because there is only a small number of people that have that level of training, and I've been turning my mind to how to respond to that.
Yeah.
And I've got some thoughts on that. But I think offering people a range of therapies is really important. Ruth Lanius, who I think really straddles, she's a professor of psychiatry in Canada, straddles being a clinician with understanding the background and the theory. She said, look, and she's trained in almost all of these modalities. She said, whether you're doing it on a group basis or individual basis, you do often have to go from one to the other. A person might improve significantly with one, and then there's another treatment, and that will get them a little bit further along the way. But it is something I'm turning my mind to because there are people in America, including Veteran Affairs over there, who want to have a word with me once our paper is published. So, yeah, it's something that's occupying my mind.
Yeah,
Are you trained in most of them?
Certainly not. I'm a very new clinician myself.
Oh.
I was wondering as well, though, so I wonder whether there'd be benefit in trying to compare this to EMDR alone as well, especially with that, testimony. It sounds like EMDR was one of the most important components, because I guess that barrier of trying to get clinicians that are able to do all of these things quite effectively, if it's significantly better than EMDR alone or not, especially the EMDR. It sounds like, I'm not very familiar with EMDR, but it sounds like that can be delivered in a group setting and that kind of stuff too.
Yes, it can be. The group settings developed by Ilan Shapiro and Lucy Artigas are very different. They've predominantly come from the background of disasters. So I think Artigas developed the first one with a hurricane in South America where, there were hundreds, if not thousands of people traumatized, and they were very large groups. So they're very different. There's a clinician in America who probably has something between that model and my model. It's in between. But yeah, the group EMDR, as it exists other than this, are very different. Very stripped down versions, in my view.
Thank you very much for an interesting talk. So with my group, we've done a little bit of work looking at mindfulness in the general population. And one of the things that we've found looking at trait mindfulness, so not actually an intervention, but a person's, I guess, propensity to live their life in a more or less mindful way, is that that seems to increase with age. And I was curious as to whether you'd noticed whether perhaps people of different ages or any other kinds of individual difference characteristics seem to respond differently to the treatment.
Yeah, I've thought about that too. Tim, was it? Yeah, Tim. I've given that thought too, and I don't know whether the numbers haven't been large enough. There's many hundreds of people who have now gone through the program, but it varies. Like sometimes really young people seem to really get mindfulness and are really into the practices, and I would have thought some of the older veterans may not relate to it, but some of them really do. So no, I've thought about whether it's a male-female thing or an age thing, and I've not been able to work that out.
Thank you.
Online question. Kieran's asking, he says, in my 10th year at Somatic, I did an external MBSR course without telling anyone, of course. It was far too taboo. But when the group discussed feeling and pointed to their chest, I had no idea what they were talking about. 15 years later, it's still a work in progress, but I meditate daily. What are your thoughts on this, being a conditioned combat soldier and also longer term evidence in years?
Yeah. So the MBSR, he's referring to the program that John Kabat-Zinn ran, and I did that program many, many years ago, and it's highly thought of, but possibly not as trauma sensitive as it can be. And I think the point Kieran makes is that's to do with the interoception. You know, he said, well, you know, what do you feel in your chest when you're breathing? And he said, well, it doesn't make sense to me. There is a part in the brain called the insula, which influences our capacity to be able to feel physical sensations in different parts of the body. It is very helpful if we can bring attention to what's happening physically, but often after trauma, people can't, and it makes no sense to them at all. And that's why it's something that I normalise. I always talk about that in the MASTr program. Otherwise, people feel, am I the only one where this is happening to? But the good news is that often with the therapies, not just the MASTr program, but if they're done individually, or they can help that problem significantly. And I'm really encouraged to hear Kieran say that he continues to practice and that it is a work in progress.
Okay, well, I think we'll leave it there. We're going to head off to lunch. I want to thank, you can join me in thanking Professor Marty Ewer for coming up today and talking. Very exciting. Thank you.
Thank you. It's been a great pleasure and a privilege.